Sometimes then there are lots of development delays, especially associated with autosomal spectrum disorder as well as ADHD into the pediatric clinics. So you may want to do organic acid testing to rule out any inherited metabolic diseases. Sometimes patients can present with unexplained liver dysfunction, especially in thalassemia type 1, where you may want to rule out. And of course, if there is a strong positive family history of metabolic disease, you would want to do organic acid testing. So normally in urine, there are more than 200 metabolites excreted. But the most important metabolite is, of course, urea. And you will also want to use an internal standard, mainly as a quality marker to ensure that your extraction efficiency is good. Otherwise, if you look at normal urine organic acid profile, there are not many peaks. From the left side, you might just see a little bit of lactic acid. If the patient had a fasting sample, you might see some ketone bodies elevated, which is part of the nutritional ketosis. Then sometimes there may be evidence of bacterial contamination, or if the patient is taking any medications like acetaminophen or anti-seizure medications like that, you will see. But otherwise, it's a clean sample. The normal urine organic acid analysis is pretty clean, and it is straightforward. So now I will discuss some interesting cases which we have diagnosed in our laboratory. So this is the first case. So I will try to label it because so that you can, it's easy for all of you to identify. Alright, so you can see here labeled in purple, there are 2 peaks of malonic acid. Okay. So this is a case of malonic aciduria seen in the urine organic acid. Normally you never see a peak of malonic acid in the urine. Okay. So when you do the plasma cell carnitine profile in these patients, you will see elevated malonyl carnitine or C3DC. So this is an organic acid disorder, and it's a very rare disorder. The incidence is about 1 in a million. If you look into literature, you'll probably find 30 or 40 cases published in the literature. But interestingly, in Qatar, we have diagnosed 4 cases of malonic aciduria. So this is an autosomal recessive disorder caused by deficiency of enzyme malonyl-CoA decarboxylase. This disorder does not present with any metabolic crisis, but they can have chronic manifestations in the form of developmental delay. Sometimes there can be manifestations like diarrhea or seizures, but in the long term, patients can develop cardiomyopathy. So this is why it is important to follow up with the metabolic team. We never know patients who die of idiopathic cardiomyopathy. If we investigate, they might actually be having an undiagnosed malonic aciduria. So the treatment is mainly preventive and supportive, so low fat and high carbohydrate diet, and if carnitines are low, carnitine supplementation will happen. Coming to case 2, here you can see along with malonic acid, there's also methyl-malonic acid. Okay. So this is a case of combined malonic aciduria with methyl-malonic aciduria. So along with the malonic acid, you will see MMA as well, and plasma cell carnitine along with malonyl carnitine, you will also see propionyl carnitine elevation. This is also organic acid disorder, but with a different mutation. Unlike malonic aciduria, here patients can present with acute metabolic crisis, and in the long term there can be developmental delay and neurological manifestations, especially in the form of loss of memory and psychiatric disorders. Can be presentation. So the treatment includes avoiding acute episodes by giving regular carbohydrate meals and follow up with the metabolic team both for the cardiac monitoring as well as neurological evaluation is important. Carnitine supplementations can be given if the carnitine levels are low. The third case, I think many of you might be very familiar with this one. So as you can see, there's a very gross elevation of methyl-malonic acid. You can't even actually see the tip of the peak. So if you dilute it, if you dilute the sample, you'll probably be able to measure it. But since this is a qualitative test, so quantitation is not necessary. So along with the methyl-malonic acid, you also see that there is elevation of methyl citric acid. 2 peaks are elevated. And there is 3-hydroxypropionic acid and also T-glycine. So these are important markers. So this is a case of methylmalonic aciduria or methylmalonic acidemia, and plasma cell carnitine will show elevation of propionyl carnitine, which is C3, and also many times C3, C2 is an important marker of this disorder. Plasma amino acids will show elevated glycine, and most of the times when we do total and free carnitine analysis, there will be reduction in the carnitine levels. And these patients typically, if they are not diagnosed on newborn screening, sooner or later, very well, they will present with acute metabolic crisis in the form of hyperammonemia, they will have metabolic acidosis, hypoglycemia, or ketosis. So this is a common organic acid disorder with autosomal recessive inheritance. So there are several types of MMA. So from the treatment perspective, vitamin B12 responsive has better prognosis. Then there is vitamin B12 non-responsive form, and also MMA sometimes can present with homocystic urine. So I've already mentioned, so the incidence is about 1 in 50,000 to 1 in 100,000 worldwide. But in Qatar, we found that the incidence is much lower. It is 1 in 20,000. So we have been doing newborn screening in Qatar since 2009, and we retrospectively looked at true positive cases from 2009 to 2023. So over a period of 14 years, we screened more than 350,000 newborns, and we gathered all the true positive cases in the population, and we published it in International Journal of Neonatal Screening last year. So based on the statistics, the incidence of methylmalonic acidemia in our population is 1 in 20,000. So these patients, more or less, if it is not treated, it's life-threatening. So they do present with metabolic crisis. So early detection in the newborn screening really reduces the morbidity and the mortality in these babies. They can also present with developmental delays, and cardiac evaluation is necessary, and they can also have neurological manifestation. So the treatment is protein restriction, restricting the propiogenic amino acids. And most important is to avoid the metabolic crisis. Mainly, the mother should be advised to feed the baby regularly. And carnitine supplementation is necessary in these patients because carnitine levels are usually low. And if it's a vitamin B12 responsive form, then high-dose vitamin B12 injections were put. And follow-up is definitely necessary with the metabolic team for avoidance of the metabolic crisis and also cardiac and neurological evaluation. Coming to case 4. So here you can see that there's elevation of methyl citric acid, 2 peaks, 3-hydroxypropionic acid, and from the left side, if you can see, lactic acid is markedly elevated. There's gross elevation of lactic acid. And you can see several ketone bodies in the form of 3-hydroxybutyric acid, 3-hydroxyisobutyric acid, 2-hydroxybutyric acid, 3-hydroxyisovaleric acid. These are all ketone bodies. There are several types. And we can also see some acylglycines in the form of propionyl glycine as well as tigliglycine. Propionyl glycine is a very pathognomonic marker. You don't normally see it at all. Tigliglycine, every now and then you can see probably trace amounts. So this is a case of propionic aciduria or propionic acidemia. So I've already mentioned the urine organic acid profile. So the distinction is, so propionic acidemia and methylmalonic acidemia, clinically the presentation is very similar. Okay, they can have metabolic crisis. And biochemically, if you do general biochemistry, both the conditions have hypoglycemia, hyperammonemia, metabolic acidosis, and ketosis. And the plasma cell carnitine pattern is also very similar. Raised C3, C3, C2, plasma amino acids are also very similar. So the most important test which helps the diagnosis is urine organic acid profile, followed by, of course, confirmation with the molecular testing. So the treatment is mainly restriction of propiogenic amino acids, and very similar to the methylmalonic acid, but the kind of protein restriction is a little bit different. Coming to case 5. So you can see here there's marked elevation of glutaric acid, and also there's moderate elevation of 3-hydroxyglutaric acid. So this is a case of glutaric aciduria type 1. In this condition, the plasma cell carnitine will show elevation of glutarate carnitine, which is C5DC. And there are many GA1s where you can actually miss the diagnosis if you're just doing plasma. So urine cell carnitine is a very important test in detecting low excretor forms of GA1. So this is an organic acid disorder with a worldwide incidence of about 1 in 100,000. But in Qatar, we found that the incidence is much lower, 1 in 32,000. So it's autosomal recessive disorder with the deficiency of enzyme glutarate dehydrogenase. So these babies, they can have feeding problems and developmental delay and several neurological manifestations. So there's risk of brain injury in these patients. So it's important to identify them early and start the treatment with protein-restricted diet, mainly for lysine as well as tryptophan. And carnitine supplementation is necessary just to help to stabilize, and avoiding fasting and follow-up of these patients for any neurological damage is very, very important for the prognosis. Coming to case number 6, as you can see, it's a very crowded organic acid profile. So you can see marked elevation of lactic acid, ketone bodies. You can see a lot of organic acids and a lot of acyl glycines. So when you see this kind of picture, anybody wants to guess what this could be? Okay. So when you see too many organic acids and too many acyl glycines, think of multiple acyl-CoA dehydrogenase deficiency. It's also called as glutaric aciduria type 2. So you'll see glutaric acid, 2-alpha, 2-hydroxyglutaric acid, ketone bodies, ethyl-malonic acid, lactic acid, sucrinic acid, all these citric acid metabolites. And acyl glycines, you'll see several acyl glycines elevation. So plasma acyl carnitine, when you do the profiling, again you'll see several plasma acyl carnitines elevated, the medium chain as well as the long chain ones. Now the interesting part is glutaric aciduria type 1 is an organic acid disorder, whereas type 2 is a fatty acid oxidation disorder. So maybe the classification was based on organic acid. So because they identified glutaric acid in both the conditions, they named it as glutaric aciduria. But if you look at the classification of the biochemical pathways or the mutation, it's very different actually. So the incidence worldwide is 1 in 200,000, whereas in Qatar we found a lower incidence of 1 in 87,000. So the clinical features here, patients can present with severe metabolic crisis, and they can also be late onset forms in the form of exercise intolerance, hypotonia, and weakness, muscle weakness, but the late onset forms have a better prognosis. They're also known to develop cardiomegaly as well as polycystic kidneys. So the treatment is mainly low fat and adequate carbohydrate in the diet. Vitamin B2 or riboflavin supplements will help, and also carnitine supplementation if it is low. Because it's a fatty acid oxidation disorder, so they are unable to metabolize the fatty acids. So adequate carbohydrates in the diet and avoidance of fasting is important. Coming to case 7, as you can see here, there are 2 moderate elevated peaks of 2-methyl-butyryl glycine and also elevation of EHA. So this is a case of 2-methyl-butyryl glycinuria, also called as SPCAD or short branch chain acyl-CoA dehydrogenase deficiency. So here, most important differential diagnosis here is isovaleric acidemia, because in plasma cell carnitine you will see an elevated C5 or isovaleric carnitine. So this is an organic acid disorder with worldwide incidence of 1 in a million, but in Qatar, 1 in 100,000. In Qatar, the incidence is much lower, 1 in 175,000. It's an autosomal recessive disorder, and this disorder does not present with any metabolic crisis, usually chronic manifestations like developmental delays, spasticity, and neurological problems. So the treatment is a low protein diet, mainly restriction of isoleucine and carnitine supplementation. Coming to case number 8. So many of you might have seen this. It's a common disorder. So there's a gross elevation of 3-hydroxyisovaleric acid and also 3-methyl-protein glycine. Both the peaks are seen. So this is a case of 3-methyl-protein-CoA carboxylase deficiency. So plasma cell carnitine, when you do profiling, you will see elevated C5OH or 3-hydroxyisovalerate carnitine. This is an organic acid disorder with a worldwide incidence of 1 in 50,000, whereas in Qatar, we found the incidence much higher, 1 in 16,000. It's an autosomal recessive disorder with deficiency of 3-methyl-proteonyl-CoA oxalase. So, interestingly, most of these patients that we follow, our metabolic physicians say that they are asymptomatic, and the presentation is very variable. They never have any metabolic crisis, at least from what we know, but they can present with developmental delay or ataxia, hypotonia, those kind of things. So they are still followed up in the clinic. So the treatment, predominantly vitamin supplementation, and in severe cases, protein restriction is used in the form of leucine. If carnitine levels are low, carnitine supplementation is coming to the next case. So here you can see marked elevation of 3-methyl-3-hydroxybutyric acid. Both the peaks are elevated. There's 2-methyl-acetoacetic acid and also T-glycine. Okay. So this is a case of beta-ketothiolase deficiency. And when we do plasma cell carnitine profile, again, here also you will see a raised C5OH, similar to the 3-MCC. So this is one of the differential diagnoses. So where urine organic acid profile helps in the actual diagnosis. It's an organic acid disorder with incidence of 1 in 1 million and deficiency of 3-oxytyrase is seen. So these patients typically they present with life-threatening metabolic crisis. So it's very important to identify them as early as possible, and treatment is necessary. Protein restriction of the diet to restrict isoleucine, carnitine supplementation, avoidance of fasting, and managing the acute crisis itself is very important for improved prognosis. Coming to case number 10, so we have 3-hydroxyisovaleric acid marked elevation. Along with that, we have 3-methyl-glutaric acid. We also have 3-methyl-proteonyl-glycine and 3-hydroxy-3-methyl-glutaric acid. So 3-hydroxy-3-methyl-glutaric acid is not commonly seen, so which is nothing but HMG-CoA highest deficiency. So the plasma cell carnitine here also you will see elevated C5OH. So we've already seen, urine organic acid plays a very important role in the differential diagnosis of the last 3 disorders. So this is also organic acid disorder with an incidence of 1 in 100,000. This is caused by deficiency of enzyme 3-hydroxy-3-methyl-glutaric-CoA. So these patients also present with severe metabolic crisis. So it's life-threatening. They need to be identified early and treated. So these patients, the long-term complications might include hepatomegaly and pancreatitis as well. So management, the treatment includes management of acute crisis, protein restriction in the form of leucine, whereas in beta-ketothiolase it's isoleucine restriction, that's important, and carnitine supplementation and avoidance of fasting. Coming to case 11, here you can see the organic acid profile showing marked elevation of 3-hydroxyisovaleric acid, and there is 3-methyl-glutaric acid and 3-methyl-glutagonic acid. So this is a case of 3-methyl-glutagonic aciduria. Here also in the plasma cell carnitine, when you do, there's just elevation of C5OH. So urine organic acid plays a very important role in the diagnosis. There are 4 or 5 types of 3-methyl-glutagonic aciduria. So the type 1, the incidence is 1 in a million. Whereas type 2 is 1 in 200,000, which is X-linked, so commonly seen in males. Whereas type 3, the incidence is more common, 1 in 10,000, mainly in the Iraqi Jewish population. And type 4, 5, and others are extremely rare. So this is the organic acid disorder, and the clinical presentation is varied, it depends on the type. And the treatment is also symptomatic. Coming to case number 12, here you can see homogenesic acid, and also 4 types of metabolites in the form of 4-hydroxyphenyl lactic acid and 4-hydroxyphenyl pyruvic acid, and N-acetyl-tyrosine. So this is a case of alkaptonuria. It's an amino acid disorder with a commonly seen, I think, throughout the world, with a worldwide incidence of 1 in 250,000. It's an autosomal recessive disorder caused by deficiency of homogenisate 1,2 dioxygenase. So because of the accumulation of the homogenesic acid, these patients have dark colored urine, and the same homogenesic acid can get accumulated in different parts of the body, causing ochronosis and osteoarthritis, lumbar spine stiffness. They also have high prevalence of stones in the form of kidney stones and prostate stones. So the treatment is mainly symptomatic and preventive depending on which tissue is affected. And nitisinone and vitamin C supplements. Coming to the next case, here you can see that there's a moderate elevation of succinylacetone along with tyrosine metabolites 4-hydroxy phenyl lactic acid and 4-hydroxyphenyl pyruvic acid. So this is a case of tyrosinemia type 1. This is a amino acid disorder with an incidence of 1 in 100,000, and this is caused by deficiency of enzyme furyl acetate hydrolase. So these patients, they have failure to thrive, and most importantly, they have cabbage-like odor because of the succinylacetone. And if left untreated, they develop progressive liver disease going into cirrhosis and hepatocellular carcinoma. They can also develop neuropathy and hypophosphatemia complex. So treatment is very essential in the form of nitisinone and low phenylalanine tyrosine diet. In the long term, most of these patients will require liver transplant. Coming to case number 14, here you can see marked elevation of 2-hydroxyglutaric acid and 2-hydroxy moderate elevation of 2-hydroxyglutaric lactone. So this is a case of 2-hydroxyglutaric aciduria. So there are 3 types of 2-hydroxyglutaric aciduria. The most common type is the L2-hydroxyglutaric aciduria. It's an organic acid disorder with incidence of 1 in million, so very rare. And most of these, they present with the neonatal period in the form of failure to thrive, hypotonia, ataxia, and many neurological problems. They don't have metabolic episodes of crisis. So the treatment is symptomatic and supportive, mainly anti-epileptic drugs and riboflavin supplementation drugs. Coming to the last case, I think many of you might be familiar with this. Here you can see some organic acids in the form of octanoic acid, subboric acid, and sebacic acid elevation. And along with that, there are 2 important acyl glycines, hexanyl glycine as well as suberyl glycine, which are elevated. So this is a case of medium chain acyl-CoA dehydrogenase deficiency, which is a fatty acid oxidation disorder. So these babies cannot metabolize fats. The main source of fuel is carbohydrates. The incidence is pretty common in the Middle East and even worldwide. So it's 1 in 10,000. And when you do plasma acyl carnitine profile, mainly the medium chain acyl carnitines are elevated, mainly C8. Sometimes C6 and C10 is also elevated. And these babies, they present with metabolic crisis when they are not fed properly. So they need to be, the parent need to be advised to feed the baby regularly to avoid any metabolic crisis. And also they can develop exercise intolerance and fatigue and muscle weakness, especially following any exercise. So there's no specific treatment, mainly avoiding fasting is important and high carbohydrate diet. And they should avoid medium chain triglyceride oils like coconut oil. Levocarnitine supplementation can be given if the carnitine levels are low. So in summary, I presented 2 cases of fatty acid oxidation disorder, 2 cases of amino acid disorder, and 11 cases of organic acid disorders. So all these cases, urine organic acid profile plays a very important role in diagnosis. And apart from alkaptonuria, which was, of course, presented later in life, most of the other cases that are presented are from newborn screening, and all the diagnoses were made in our laboratory. So, thank you very much. So, when you start the methodology, okay, as part of the validation, so there is a software with an inbuilt library, okay. So that will identify certain peaks, but you need to validate over a period of time. So what we did was, with our metabolic physicians, with the known cases, we got some organic urine, okay, and then we validate it over a period of time. And also we get external proficiency testing, which we can order. And yes, so it takes time to build your own library. There will be some basic library, but you need to validate that your methodology is matching to identify those abnormal metabolites. And also you add more as you go along. You build your library. Thank you. It's the mix. It's the mix. It's the overall population expense that represented. Thank you very much.
Thank you very much. A special thank you for everyone who stayed back. And a special thank you to all our esteemed speakers. We had an amazing day, amazing presentation from all of us. It was very enriching. I enjoyed each and every topic. Thank you very much, and I'll see you next year, 2027.